Well, thank you for the invitation. It was pretty nice to hear about the Indian context. So let me get started without further ado. So I'm going to talk about mixed or combined acute cellular and antibody rejection today. I do have a few disclaimers. So let's talk about the definition of mixed rejection first. As I'm sure most of the audience knows, that the initial definitions of rejection in kidney transplants were first identified and described in this place called Banff in Canada. It's a pretty beautiful place, and I would recommend going there if you ever get the chance. But talking about the definitions of rejection, you have acute T-cell mediated rejection or acute cellular rejection on the left here, which includes interstitial inflammation, tubulitis, and on the right side is active antibody rejection, which includes microvascular inflammation and or vasculitis, evidence of complement activation by C4D staining, and then we've added gene expression now by endothelial-associated transcripts recently, and evidence of donor-specific antibody. But as many of us know, these definitions have been changing over the last several years, and I'll talk about why that matters. But mixed rejection essentially is a combination of these findings, and that's kind of how we define that. So how does mixed rejection impact outcomes? And in this slightly older paper, what you can see is that in the dark solid black line, you can see the outcomes of pure TCMR, which are fairly good at the end of 5 years or so. But when you look at the outcomes of pure antibody rejection or mixed rejection, they're pretty poor at close to 30%. So truly speaking, mixed rejection seems to carry a much worse prognosis than pure TCMR. Now, if you look at the patients with TCMR who have donor-specific antibody, they do much worse compared to those without DSA. And the same is true for evidence of complement activation, where diffuse C4D portends a much worse prognosis than none or focal C4D staining. So essentially the message is when you add antibody-mediated processes to TCMR, the outcome becomes much worse. And that's largely because of the fact that we don't have good therapies for antibody-mediated rejection, as we all know. So this is a flip side of the question, which is amongst patients with antibody-mediated rejection who have TCMR, how do they do? And what you can see is with this red line, patients with concurrent TCMR have much worse outcomes than patients without concurrent TCMR. And of course, that means they have mixed rejection. And the second point, of course, is patients with chronic active AMR have much worse outcomes than patients with just active, meaning no chronicity on their biopsies. Once again, these are obvious things which we now can appreciate pretty easily, but this is older data. So the second point which I want to highlight for you all is the time to biopsy. So what we definitely know now very clearly is that the prognosis of early rejection, usually within the first 6 months of transplant to up to 12 months, is much, much better than prognosis of late rejection. And that's what this slide points out. Similarly, evidence of proteinuria, which typically means that there's chronic active antibody rejection, once again portends a worse outcome. So, but what you can see is that the outcomes of these papers are varying. And a large part of the problems we have with regards to treating patients beyond inefficient therapy is also definitions of rejection. And Banff classifications, like I mentioned before, has changed over time. Criteria have changed, but beyond that, there are deviations by individuals to applying these rules. And then finally, and most importantly, the lesions which we use to describe rejection are not unique to each process. For example, you can see peritubular capillaritis in TCMR, and you can see V lesions in both TCMR and EBMR. To give you an example, here's a slide from a patient of ours where you can see pretty significant inflammation everywhere, interstitial and tubular. If you go to high power on the slide, you'll see the space which is the peritubular capillary space where you can see inflammation again. So is this a patient with mixed rejection? Actually, this patient turned out to have BK virus nephropathy. So truly, it is very important to ensure that we are treating the right patient for the right diagnosis. and the whole clinical context becomes important. There are neurodiagnostic tools which are now becoming available, and I'll share that with you. So in our center, we use this test called the molecular microscope, or MMDX for short, fairly routinely. What it does is that it identifies for every kidney biopsy, it looks at gene expression and then assigns a disease state to every single biopsy. And as many of you may be aware, this is an international project spanning many, many countries and continents, and it comes out of Edmonton from Dr. Philip Halloran's group. So what we've done in this project is to assign 6 archetypes of rejection to every biopsy. And you can see them here projected into this disease space where there's no rejection, different kinds of ABMR, early, fully developed, and late-stage ABMR, TCMR, which is pure TCMR, and here, which is the severe mixed rejection process. You can also flip the axis by 90 degrees, and you can see the ABMR spread out over 3 different states. But then when you get a new biopsy, you project that into the space, and that's how you arrive at a diagnosis for that new patient. So for this talk, I'm just focusing on this particular disease state, which is the severe mixed TCMR/ABMR state. And as I'm sure all of you are aware, the primary determinant of mixed rejection is non-adherence to medications. And that may be unfortunately intentional because of different reasons, or iatrogenic in some cases. So what is the value of these disease states? Now, one is that they vary with time post-transplant. In these cohorts from primarily from Canada and US, mixed rejection typically happens and peaks with this green line at around 200 days post-transplant, but then by 5 years or so, it pretty much goes away, and ABMR states develop over time after that. The second benefit of these classifications is prognosis, and as you can see, like before, that mixed rejection has a worse outcome than T-cell made rejection. So why is this again important with regards to managing patients? And that's because of misclassification in histology. And this is a paper we just published at the end of last year, where what you can see is that on histology, amongst all the patients with mixed rejection, nearly half had either pure ABMR or pure TCMR, 10% or so, based on one MMDX. And that kind of makes it important because the managements associated with these disease states are different. Now, since everybody does not have access to these tests, what I would suggest is that we have to look at other factors, kind of looking at the whole clinical context of the patient to arrive at a diagnosis. So with regards to history, the 2 primary things to think about are a history of non-adherence to medications, and tacrolimus trough levels. For example, if a patient has variable levels which go up and down wildly, or they're consistently very low, as well as socioeconomic risk factors, which may associate with compliance, presence of DSA. And then for histology, the primary determinant would be interstitial inflammation, in my view, because you can see mild tubulitis in ABMR, but you should never see severe interstitial inflammation in ABMR. So in a patient with severe interstitial inflammation, or I, that argues strongly in favor of mixed rejection rather than a pure ABMR-like process. So let's move on to therapies now. So again, this is not new stuff. Of course, all of you, I'm sure, are aware of this. So on the left, you have therapies for acute TCMR, which are pulse steroids or antithymocyte globulin, or ATG for short. The older studies describe intensifying immunosuppression, converting patients from cyclosporin to tacrolimus, or azathioprine to mycophenolates, also for these situations, but probably not adequate on their own in the modern era. On the active ABMR side, you have plasmapheresis, the IVIG, which is a center of care. And then you have other therapies like B-cell depletion and plasma cell depletion, which can be tried, although the evidence is not entirely clear. And then there are newer emerging therapies, which I won't talk about for this talk, but I think Dr. Samaniego will do that after my talk. So for mixed rejection, once again, the key is going to be how do we combine these 2 therapies, and whether we actually do that and what benefits it may carry. So the data for therapy is very, very poor. And the only thing I could find in the literature is a single abstract from 3 or 4 years ago in the American Transplant Congress. And these authors from Cincinnati, they randomized close to 30 patients with mixed rejection to one of three therapies, either ATG plus plasmapheresis of 3 sessions, or ATG plus Plex plus rituximab, or the same plus bortezomib. And they biopsied every patient right after therapy, and they looked at outcomes at 1 and 3 years post-kidney transplant. So if you look at the demographics of these patients, you will notice what I mentioned before, that a majority of these patients had late rejection more than 6 months post-transplant, and that automatically generally means poor prognosis with all the therapies we have. Once again, they were late rejections. You can see the time from transplant to rejection was 1.4 to 3.8 years on an average. They had pretty poor kidney function at baseline when they were diagnosed with rejection. And then a majority had class 2 DSA. With regards to therapeutics, we are well aware that class 2 DSA does not respond very well to pheresis as well as to plasma cell or B cell depletion compared to class 1 DSA. So looking at the outcomes of these patients, so right after therapy, creatinine went down nicely in all the 3 groups, but it wasn't sustained. Over time, the creatinine went up again in these patients. Similarly, antibody went down right after therapy, but like I mentioned before, creatinine went up again. And if you look at the graft survival of these 3 groups, there's no difference. So what this means is that if you add rituximab or bortezomib to ATG for patients with mixed rejection, there is no benefit based upon this trial. So what changed with therapy though? So what you can see is the pre-treatment BAM grade of TCMR for these patients versus post-treatment BAM grade. And what you can see is that the grade is going down. So for example, for 1A or 1B, nearly half the patients had a reduction in their grade of rejection. So therefore, what is changing with the treatment of TCMR of mixed rejection is sterilizing the TCMR component of the rejection, while the ABMR component does not get response by treatment. Once again, that's kind of understandable, as we know that therapies for ABMR for patients with late rejection is not as effective. Similar data from another group where they found that rituximab or bortezomib resulted in no impact in graft outcomes. But when you look at ATG, you start seeing a trend here. Now you'll see that in this graph, the p-value is not significant. But if you look at up to 6 years, up to 5 years here, the red line, which is graft survival, is better for the patients who got ATG versus those who did not. So there seems to be a benefit of ATG for mixed rejection based upon this data, although it's not entirely clear. So with that, let me share a case with you from our own center. So this was a 46-year-old female. She got a kidney transplant close to 1.5 years ago. She admitted to being depressed, and we suspected that she had non-compliance because of that setting. And she had a rise in creatinine. And this is where we did a kidney biopsy on her because of rise in creatinine. Her biopsy showed 1A TCMR along with antibody rejection. And I mentioned to you that we do MMDX on all of our patients. And this is what her data look like. So the biopsy report is abnormal biopsy with severe ABMR and TCMR. You can see the projection of this patient with this triangle in the R3 space, which is the mixed rejection cohort. So consistent with our histologic diagnosis for this patient. So she got treated with thymoglobulin or ATG plus plasmapheresis with 6 sessions. And you can see rapidly her kidney function improved. But then over time, as you see, the creatinine goes up again. And once again, it's slowly creeping up over time. So what is happening here? So we did a kidney biopsy for her here, where it was done for surveillance. And you can see chronic active ABMR on this biopsy. So once again, as I mentioned to you, what is happening in these cases is that you sterilize the TCMR, but the ABMR continues unabated. So in our view, we have kind of given up on treating the ABMR component for late rejection at this point, and we try to focus on sterilizing the TCMR component and then provide therapies which may enhance the survival of the transplant in the long term rather than reversing the rejection process, because that may not be achievable. And although this will be a different talk, very briefly I'll touch upon that. We are using belatacept for patients with chronic active antibody-mediated rejection with a prolonged CNI taper. And with that, we are seeing pretty interesting responses. Our paper was just published the last 2 months ago in Transplantation. And what you see here in this cohort of patients with chronic active ABMR is that prior to conversion, their GFR continues to get worse and worse and worse. And then after conversion, this seems to stabilize. And it has been so at 2 to 3 years of follow-up. And they have better kidney function in this group versus control group, which was maintained on CNI therapy. So what can we do to identify which particular therapy to offer to individual patients? So the group in Paris has done most of the work on this. We have collaborated with them for many years now. This is the paper that was just published in the last 2 or 3 weeks in Kidney International. So what they tried to do was they looked at 14,000 patients with their GFR measurements, and they tried to identify trajectories of GFR and outcomes in these patients based upon their diagnosis and based upon their GFR trajectories. So you can do it for your patients also. You can go to this website here, which is listed at the bottom, and you can put in your patient information, which I did for the patient I shared with you. I put in the DSA, the GFR, as well as the biopsy criteria at the time of the initial diagnosis. And then the system will give you a kind of prediction for what that particular patient may do. So in this case, for my patient, the patient fell in this class 7, which means that her GFR would remain low despite therapy, based upon the 15,000 patients that were studied before. And she will lose an average of 3 points of GFR per year in the long term, with a resultant graft loss and graft survival of close to 40% at the end of 10 years. So this is something which we can use to identify how we should treat our patients. Now keep in mind that this is based on contemporary traditional therapies, and we don't know what's going to happen when newer therapies evolve and become available to our patients in the future, but this is the best we have right now. So let me end with the last slide as to how do I treat mixed rejection. So first of all, I would treat the TCMR always. And the way we do that is by pulse steroids for 1A and lower, and ATG for 1B and higher, BAMF grade TCMR. For early rejection within 6 months of post-transplant, we do treat the ABMR component. We would typically use a combination of plasmapheresis with IVIG. The role of drug therapies is unclear. Whether they work or not is also unclear, but usually many of our patients may get a combination of both these drugs, but in a minority, we would not give them if it is felt that they would not help the patient if there's already significant chronicity on their biopsy. For late rejection, more than 6 months post-transplant, with or without chronicity, we do not use ABMR therapies anymore. We do use the tools I described to you in the last 2 slides. There's a question whether newer drugs like IL-6 blockers, tocilizumab, may help. I shared the data about belatacept with you. That's evolving. We will have a lot more data in the next year or so. But then most importantly, we need to look at the psychosocial and economic factors for non-adherence and correct them as possible. Now, particularly in the Indian context, that becomes the most important thing to think about, because cost, of course, as I heard in the last talk, is a very, very important factor to determine before we offer these expensive therapies that may or may not work. And I think that's the last slide. Thank you for your attention, and thank you for the invitation.